All right, good afternoon, guys. I'm giving what I'm told is the last lecture of the day, and you've all eaten, so... All right, good afternoon, guys. I'm giving what I'm told is the last lecture of the day, and you've all eaten. So if you could stay awake and with me, that would be a job well done. That's all I expect. So I'm going to be talking about sepsis, which I think I can get through pretty quickly because not much has changed in the last year or so. But I think it's important for the interns. Are there mostly interns here? Or are there any interns here? Just the 1, 2, 3? That's it? Well, this will go down a treat. Okay, so I'm going to talk about this, a little bit of background about sepsis, why it's so important for everybody, especially at U of L, and a little bit about the background of the disease, the syndrome that it's now associated, now otherwise called, and then more importantly, recognizing and treatment, because that's ultimately the most important thing. So sepsis is by no means a new phenomenon or a new syndrome or disease. It has been recognized since the beginning of time. So I put some quotes up here from way back in the day, essentially to highlight the fact that we recognize that there was always an invasion of the human body from other creatures or pathogens that caused the body to have an overwhelming reaction or response that we now recognize as sepsis, but even a very long time ago was recognized as pathologic and led to lots of death and mortality, morbidity. So as we have learned more about sepsis, we've obviously tailored our treatment approaches and recognition, which are the 2 most important things for sepsis. And so this is essentially sepsis through time, but most importantly for us clinically is the Surviving Sepsis Guidelines and Campaign, which all kicked off around 2004. So in 2004, or just prior to that, there was a lot of interest, a lot of studies being done in sepsis. What causes it? How do we recognize it? How do we treat it? And how do we improve patient outcomes? And so once they had enough of this data, they released guidelines. So in 2004 was the first set of real guidelines that came out, just defining what sepsis is, how to recognize it clinically, and maybe some recommendations on treatment. And then over the last several years, these guidelines have been revised. Most recently in 2017, 16, 17, the latest revisions came out. It's important to understand the context from the first set of the guidelines to the most recent ones because the evolution is important and the most recent guidelines are obviously what we use clinically, but it's important to know where they came from and why we do what we do. So some background as to why sepsis is so important and why I, personally, and a lot of us here harp on about it and the importance of recognizing it. So it remains, we're calling it now a syndrome or a disease, but it remains something that has such a high incidence and prevalence, and the mortality associated with sepsis is on the rise. So if you compare this to other diseases, which are considered medical emergencies, such as an MI, so a STEMI, or a code stroke, all of those diseases are actually either on their way down or the treatment has gotten so good that we recognize it earlier and patients have better outcomes. That is not the case with sepsis. It continues to be on the rise, and death associated with sepsis continues to be on the rise. So that's why, from a medicine perspective, we're really trying to give sepsis the same limelight that these other medical emergencies receive. Now, pathogens that are associated with sepsis have changed and have been evolving over time. Gram-positive bacterial infections remain the most common, but essentially bacterial infections are the most common cause of sepsis. But fungal infections are also on the rise, and that is partly because of people who have a low immune system are living longer, surviving through more things, and so we're recognizing this disease or syndrome in this patient population. There's also a lot more immunocompromised patients out and about, and so fungal infections are becoming more prevalent. So just to give you some context, about 1.5 million people are diagnosed with sepsis each year in the United States. About 250,000 of these will die, and that is up there with heart disease and strokes and cancers. 1 in 3 patients will die in the who die in the hospital will die of sepsis. And I'm sure you guys see this on wards all the time, and you definitely see it in the ICU. Most of the patients who are septic, it is from outside of the hospital. So most patients come in through the ED with sepsis. That's what brings them in. And then what happens in the hospital is just as important, obviously, but most of your septic patients were septic from the outpatient setting. It was either not recognized or not appropriately treated from their physicians, and then ultimately got worse and they came in. And the remaining is inpatient sepsis. So, excuse me, patients who have been in the hospital for a long time, who've developed a hospital-acquired infection or a complication from another infection. And that is also true to U of L. So we're pretty close. We have our septic patients, about 70% of ours come through the ED. We have a slightly higher than we would like rate of in-hospital sepsis, but that's a whole other problem. And just so you know, the most common source of infection is pneumonia. So its most common cause of sepsis is usually in the lungs. Whether it's a community or hospital-acquired pneumonia or an aspiration pneumonia, the lungs are the most common source, followed by UTI, sepsis from UTI. And then other things, cellulitis, skin infections, GI infections, those sorts of things are common, but not as common. So as I talked about, it's the 3rd most common cause of death. So it is a huge problem, both for the country and for you as clinicians dealing with patients on a day-to-day. The death rate from sepsis equals that of MIs. MIs currently on their way down, let's say, or recognition, obviously, of an MI is done much more frequently and with ease compared to sepsis. In the ICU, it's the leading cause of death. So those of you that have been in the ICU already see that, for the most part, it's a fellowship in sepsis with a few other things that we do. And just to make it relevant from a clinical perspective, it's also a very costly syndrome. And a lot of that is because it's not appropriately recognized early on. Okay. So the initial Surviving Sepsis campaign guidelines came out. It categorized sepsis or infections in this way, starting off with plain old infection and moving all the way over to septic shock. So it's sort of a spectrum, starting off with an infection that perhaps then causes systemic problems and ends up in shock. So you have to be able to recognize these various symptoms along that spectrum in order to prevent patients from getting worse and moving down that spectrum. So first off, it starts off with infection, and I think it's important to recognize, and we'll kind of talk about this a little bit later, but having an infection is not the same as being septic. You can have an infection with any pathogen, viral organism, and not be septic. Once you are septic, that's pretty different, and that actually moves you to a different category, as we can see, and that therefore changes your mortality and morbidity. So you can have somebody that has positive cultures but is not septic, or you can see somebody in the clinic that has an infiltrate on chest x-ray but they're not septic. So I think it's important to make the distinction, especially on wards when you guys are rounding. If you're seeing patients who have an infection, it doesn't mean that they're septic. So to be septic, they have to meet certain criteria. And that criteria is that they have to have SIRS criteria plus a source of infection. That combination means your patient is septic. Now, it doesn't take a lot to be septic, but it's an important distinction to make, especially from a documentation perspective, which I know is not everybody's favorite. But if you document somebody as septic, then you've attached a specific mortality to that patient. If you just say they have an infection, it's different. Likewise, if you admit a patient and say they have an infection and they die 2 days later, something's gone horribly wrong. So you really have to try and make the distinction between a person who has an infection secondary to pneumonia or UTI versus a patient who is septic. So to have a source of infection plus SIRS criteria, which we'll talk about, puts you at septic. To then have severe sepsis, you have to have organ dysfunction, and it can be any organ, so not necessarily the organ that is causing the infection. And then from there you can have septic shock, which is exactly that. You are now in shock despite being resuscitated. So you have to have given the patient resuscitation, they continue to be hypotensive, and that is called septic shock. So this is a pretty good model that basically shows you start up at the bottom, you can have SIRS criteria and not have an infection, or you can have an infection and not have SIRS criteria, and the combination of the two leads you into sepsis, and so on and so forth, up until you get to septic shock. As you're moving up, your severity of illness obviously goes up, and your chances of organ dysfunction is also rising. Okay, so for the handful of interns in the room, which one of you knows which one is SIRS criteria? So A, B, C, or D. I'm going to let you read it yourself. You can do the correct thing. Okay, so your SIRS criteria. It's important to know what your SIRS criteria are because it's used as a really quick and fairly good screening tool. It's typically now recommended that the ED uses it more than inpatient sepsis diagnosis, but it's a very helpful tool. So essentially it is looking, you have to have two of the following. So you have to have a temperature above 38 or 100.4 or below 36. You have to have a heart rate above 90, breathing rate above 20, and a white count greater than 12 or less than 4, or 10% bands. So the 10% bands often gets forgotten, but that's an important distinction to make as well. So any two of those and you have SIRS. So if you have SIRS, do you have an infection? Not all at once, please, just one at a time. No. Okay. So what else could give you SIRS but not give you an infection? Yes, so traumas, traumas, burns, seizures, other types of shock. All of those things will give you those two, at least of those, without truly having an infection. If you think about what we do clinically, most of those patients are getting put on antibiotics as they come through the door, which again is why it's important to make that distinction. Are they truly septic, or do they just have a response to something that's happened to them? So this is other things that can cause SIRS that is not an infection. So we've moved up now.
I sent good Mad Master. Did you check your email?
Yeah, I checked it.
It's for because Dr. Kozlowski is doing telemedicine.
Sure.
So I talked to Naeem already this morning. That his ear exam needs to be on point. So I sent him that thorough neuro exam, how to examine the patient from head to toe. If a stroke patient or something comes in, he needs to. So I sent him and Dr. all that already. Okay. And I sent the ICU residents, vasotropes, mechanical ventilation, all these things that they need, should be watching right now if they have downtime. They're dealing with sick patients up there, right?
Exactly.
Dr. Salaji is only a consultant. Remember, he's not
It's
ICU.
open ICU.
It's an open ICU. So I'm trying my best to make sure you guys have the resources up there.
That's great. I think when you said everybody will have in-person interpreter, what was meant by that on the email for the clinic?
You will have Paula, someone else will have Ada, and someone else will have
And we'll be doing like video chat with them?
only phone for
Phone
today.
chat.
Let's see how today works. There's some model that's used in disasters. It's actually taken from a technology model. It's called Scrum. Have you ever heard of it? It's you do something, then you go back and you evaluate what could be done better, what it could be done. What went well, what didn't go so well. How can we do a better job tomorrow than we did today? And today is just one resident, one interpreter, calling the patients.
We'll see how it goes.
Let's just keep an open mind, see how it goes. If it goes, and then your feedback, everyone, attending's feedback, the resident feedback. How can we do a better job tomorrow? Okay?
Sure.
So it's progress over perfection.
I understand, you're right.
COVID situation.
Correct.
But please emphasize to the residents, if you see them, that I have access for 20 residents from Med Mastery. They should be watching this because it's them who are going in. I know what happened yesterday night in the ICU, where they had to go in and the patient was extubated.
Yeah, they said something about that. I told them to call.
But these situations will happen again, When you're the doctor over there, the nurse is going to look at you. If the ICU the ventilator patient starts having a Lucas plug to these lectures on dependent learning, thinking matters more now
Correct.
than ever before.
So I'll send a text to everybody, if you need access.
Like, please, I already have Actia. If anyone else wants an access, anyone's covering the ICU, on the weekends,
Sure.
things like that, okay?
Thank God.
Sure. Excuse me, let me wash my hands now. Maybe I didn't use the other one. This, I wanted to give this to you. I haven't pulled those out today. Later tonight. Let me wash my hands.
Oh, okay.
We feel that septic shock should obviously be in the ICU because they require aggressive treatment, but we
Oh my God,
particularly
guys.
feel that they have to require resuscitated. And often the ED has not done that, right? They thought you could finish shock, they want the unit, but you have to appropriately resuscitated, still be in shock. That means you need aggressive treatment. This is what we're talking about, the acute phobia versus the SIRS criteria. So when you apply the SIRS criteria to your patients, you're going to get in that subset of patients people who have SIRS but do not have an infection, like we talked about. And so when you initially screen them, we go back when we are assessing patients in the ED or who come up to the floor with a Q SOFA. And we do that to then try and find those patients that have a true infection in that subset of patients. The Q SOFA is much better at identifying patients who have a true infection of SIRS or sepsis versus those who just have a positive SIRS. So, which one of these is the Q SOFA criteria? Anybody? 1, 2, or 3? 2. Okay. These are just the questions. So 2. So if you look at these, almost all your patients are going to meet this criteria, right? I mean, I'm sure you guys are in ED all the time. A rate above 22, altered, blood pressure less than 100. It's almost everything you get called for, right? So this is helpful. So when we use it, it's once a person has met SIRS criteria, we're trying to tease out if they have a true underlying infection. So we moved from the first set of the sepsis guidelines over now to this second set, or the next surviving sepsis campaign. And they changed the definition a little bit based on what we now have as good data and many clinical trials. And they changed this life-threatening organ dysfunction, so what was severe sepsis that we moved away from. And that is because over the last 15 years, there's been a lot of studies and research and well thought out clinical trials that have gotten us to this set of definitions. And so now sepsis, rather than being a disease, is considered a syndrome. So the infection or the pathogen that gets into your body is not the problem. It's how you, the host, react to that pathogen. Everybody has differing reactions. And so the extent to which your body puts together an immune response to fight this infection will determine how sick you will get. So it's a syndrome. And so we now look at various markers to identify infections, sepsis, levels of sepsis, so to speak. And these markers are all associated with infectious septic patients. The one that we most notably use, I don't know if you all know, is the procalcitonin. We rely quite heavily on that. But all of these markers are abnormal in patients who have an infection, which is basically going to show that this is a systemic reaction. Your body is reacting to an invasion from an organism or a pathogen. And so they elevated the status of the sepsis syndrome from essentially not anything significant to a medical emergency. So at some point in the future, you could imagine this being a code sepsis, and I guess in our case, in current tense. But just like you get a code stroke or a code STEMI, you should theoretically be getting a code sepsis. As I'll move on to talk about, there are very specific ways to treat this, and there are timelines that you have to hit, both for treatment and for recognition. So you can almost imagine this being the case, except that because it is so common and prevalent, it would be going off all of the time. So we're still trying to find ways to be more sensitive and specific, but this has now been elevated to the same status as these other medical emergencies. And so where did we get all of this information from? So back in the early 2000s, this was a landmark trial by Rivers who was one of the first people to really start the early goal-directed therapy and basically bundle care for patients with sepsis. And what he and his team did was try and find ways to treat patients with sepsis and septic shock to try and improve outcomes. And they focused on various different things throughout the protocol that they put together. So the first thing they did was to try and aim for a specific CVP, MAP, and an SCVO2. Basically trying to make sure that the patient is well perfused, either with fluids, blood products, whatever they could to get the blood pressure up, because if you can keep their pressure up, you're perfusing the organs and hopefully preventing any end organ damage. They were aiming for CVPs, they were aiming for MAPs, and they were aiming for a mixed venous. And depending on what numbers they were getting for these would depend on the treatment they would give those patients. So at the end of the trial, they were recommending that you put in a central line for all of your septic patients, and you measure essentially a mixed venous, and that you give, you use that also for CVP, and that you give fluids and or blood products to help keep your MAP above 65 and to help keep your SCVO2 high if you would give blood products. And then you use pressors early, so the dopamine or other pressors to help keep your blood pressure up. And that essentially became the standard of care for 15 years or so, and it was associated with improved outcome and mortality in these patients. And the study essentially was one of the landmark trials to help us introduce a very stringent way of approaching the septic patient, and it's very algorithmic. The goal was to correct any hypovolemia, any hypotension, and in some cases, to help prevent end organ damage. And these concepts are the same that we're still using today. It's just the way that we go about measuring some of these things has changed, and we've changed some of the limits that we're aiming for. Essentially, about 10 to 15 years later, we redid a lot of this trial again. We did the trial in similar ways. And these three trials came out. One was here, one was back in England, and one was in Australia. And they used what was standard of care versus early goal-directed therapy, so the kinds of stuff that Rivers was doing. And they found no difference 15 years later. But what you should remember is that standard of care from 15 years ago is completely different to standard of care now, because now we know that blood pressure is important, that pressors are important, that checking these things are important. So the reason we think there's no difference is because most people are getting what is standard of care that they were not getting back in the early 2000s. But this essentially changed a little bit about what we do now in practice. And so following these big trials is what led to the most recent surviving sepsis guidelines. So I'm going to talk a little bit about those and why they're so important to do, but also why they're so difficult to do. So if you are called down to the ER to see your patient, the ED has done half of what they're meant to, so they've got some labs for you, and the patient is clearly septic and perhaps heading towards shock. These are the things that you want to be going through. And the single most important thing for the septic patient is what? Okay, antibiotics. So it's antibiotics every single time for every single patient, no exceptions. No waiting and seeing, no nothing. It's antibiotics. It's your number 1, 2, 3 things to do for every patient. And I understand it's difficult both logistically and just to get down there to see the patients, but it's the single intervention that correlates with improved outcomes. So it's antibiotics. And then you can worry about fluids, which is your second most important thing. Okay, so the latest sepsis guidelines came out in bundles. There is a 3-hour bundle and a 6-hour bundle, and at the very end we'll talk about a 1-hour bundle, because now it's a 1-hour bundle. And that is from the time the patient enters the hospital. So realistically, a 1-hour bundle is going to fall on your ED, but if you're getting called for an inpatient, then you need to get the inpatient seen very quickly. But your 3-hour bundle, so the first thing you want to make sure happens, and again, a lot of this should be happening in the ED, but it doesn't, so you need to make sure that you're checking for these things. So the first thing is blood cultures before antibiotic therapy. You want to know what organism, if any, your patient has. You want to measure baseline serum lactic acid. That is very important, and it is one of the bundle. measures. You want to give antibiotics. I guess that one should have come before measuring the lactic acid. You want to give antibiotics as soon as you draw blood culture and you want to measure your patient's lactic acid. And you want to give fluid. And we recommend 30 mL per kilogram of crystalloid fluid for almost everybody, but definitely hypotensive patients or patients with a lactic above 4. Now, to unpack this a little bit, if your patient is 600 pounds, you don't want to give them that much fluid, right? It's for your ideal body weight. So just be aware of that. And if your patient has an EF of 10%, this rule still applies. If they are EF of 10% and they've got lower extremity edema and they're on 5 litres of oxygen, this rule still applies. Okay, so that's one of the biggest things that we see in this institution is that they are getting conservative fluid resuscitation of 500 cc bolus. The ED is guiding them straight onto a pressor, so they don't get any fluid resuscitation. But this rule applies. If they can take it, and most patients can, they need to get their fluids again.
Some of our ER residents hang their hat on expected transfused fees. Over lactates only 2.8. They don't need the 30 ml and they've given a liter of which many of us are not. So I'm still encouraging them, and I at least did help them. But I presume even with a less than 4.
Yeah, so less than 4 is
Sorry,
not
Captain.
Hypertension,
This
obviously,
is because Louis will lecture sepsis. I actually thought that the whole faculty will be in the meeting.
Oh, is there a meeting? I don't know.
Now,
Yeah, so regarding the same COVID issue, it's been moved to like 1 now. So that's why.
To a patient that looks so clearly fluid overloaded or is hypoxic or has low EF. And there is no talk about some literature that warns against too much fluid, which is also very important. But historically, we were giving patients, 5, 6, 7, 8 litres. And that, we don't do that anymore. That's not appropriate. But the 30 ml per kg is tailored to that patient's
Just one more question.
So should be very safe. Now, the latest guidelines
start with the
recommend
732?
that you are constantly
832,
monitoring your
529,
patients.
yeah.
If they are
529, yes.
going to
I'm
need
gonna
3.5
say
litres,
Yeah, I just actually
you're 2 litres in, and suddenly they went from 5 litres to 12 litres.
Here's
That's
the list.
different, right?
No,
You may want to come
Yeah, if
back
you want to,
and
like,
reevaluate
if you have like
things.
a group, send it out
But
to
the
people now.
recommendation
And your name is
is
Adam
giving
C. or Adam
priority
K.
of
Kaplan?
what they should
Adam
be
C.
getting
Kaplan.
when
And that's
they
with a
should
C?
be getting. And this
What's
is
that?
given
With a
them
C?
to
No,
prevent.
Kaplan with a
And
K.
then obviously I'm biased, but from an ICU perspective, you can be surprised how many patients
Feel
there
free,
don't
so
need to
text
be
me,
on
cell
ICU
phone,
because they've got
open
extra
book,
data
so
and
anybody can anytime call and text me.
Okay, I'm gonna put it on the journal.
And just to let you can start spreading it. I'm a horrible texter, so if you text me and I don't get back right away and you really need me, just call.
The 3 hours, that's the
Oh,
first 3 hours,
thank
right? Patient
you.
comes in,
Thank
you.
cultures, antibiotics, check the lactate, give them some fluids. In an ideal world, that's the ED's job, right? Now the ED is picking up the phone and calling you. I know realistically that's not what happens, but you're getting the call now after all this stuff's been done. So you're on the 6-hour bundle team. And so what you want to be assessing was fluid responsiveness. Did they respond to fluids? Because if they did, then if they did not, then your treatment is going to completely change. And so if you did not, then we're recommending vasopressor support for persistent hypertension. So that is a MAP less than 65 despite aggressive fluids. We recommend measuring CBP and SCVO2. This really doesn't happen, or the repeat lactic acid, which should be happening. So after you've done your initial set of treatments, you want to get a repeat lactic acid. If your lactic acid is coming down, your patient should be on there. If not, then you need to revisit what we're doing. CBP and SpO2, so these guidelines are the second step, the most recent step. This is still part of your bundle, but we're moving towards more dynamic measures of blood pressure, which you guys will know about and do. What you have to do is a physical exam, and you have to see if they responded to fluid. So if they still look clinically dry, you can go above that amount of fluid. If they're not, then you obviously will change your treatment, but you have to do a physical exam. Those of you that were part of this team know that the physical exam was very important. You have to document your physical exam. So the 1 hour bundle, which is essentially impossible to do, but it basically is saying that you need to do everything in the 3 hour bundle in 1 hour. So the patient comes through the door, and as soon as you see them, you want to do everything, which is get your cultures, give the antibiotics, measure the lactic, and give them that fluids within 1 hour. I've yet to see that happen anywhere, but I believe it's the recommendation. And even practice. So I'm not sure how you would get your fluid in within an hour. We measure everything necessarily practice, but you have around an hour to do that. And the reason is that. Well, that's the question first. So if you come in through the door and lactic acid above 2, what is your mortality in hospital mortality? A, B, C, D. Yeah, it's a real stunner. It's 25. Right? Your chances of mortality with lactic acid above 2 is 25. And I think I've told this to some of the resident interns that I've worked with. If you need a vasopressor, it's 30%. If you are having a high lactic acid, hypertension, and oppressors, it goes up to 42% mortality, which is extremely high for something that is preventable, very preventable. For every hour that you do not administer antibiotics, your survival decreases by almost 8%. So if you just imagine going from a 1 hour to the 3 hour bundle, that will change your mortality and from the 3 to the 6. And just to give you guys some context, UofL has a time to antibiotics of about 9 to 13 hours. So we are not where we would like to be. It's getting better, it's gotten better, but prior to pretty recently, all those hours, that's mortality that is clocking away. Okay, so antibiotics, what should you give? Should you give 1? Should you give 3? The latest recommendations are that you should give the antibiotics that are appropriate to the patient's source. If the patient comes in with an pneumonia, you should give them an antibiotic for that. If it's for cellulitis, you should give them for that. If they have risk factors such as healthcare-associated infections, you can tag on a second antibiotic. But if you don't know, which is what we typically do, you put them on broad-spectrum antibiotics and then you de-escalate at the earliest possible time. So it's a very strong recommendation for antibiotics very early, broad spectrum if you need them, double coverage organisms that you think are the patient may have if they have resistant organisms, etc. Cultures. So you culture anything and everything you can. Okay, so blood, urine, sputum, chest X-rays is your staple. But if they have a source that is outside of that, so a skin infection, for example, or bone infection, if you can culture it, biopsy it, you should. To try and understand the offending organisms, you can tailor your antibiotics and then ultimately de-escalate. The other thing that you want to do is control the source of infection, which is a little harder to do. So if your patient has abscess, for example, that is an intra-abdominal or pelvic abscess or something like that, you really need to have somebody come and drain that or remove it or remove the source, because you can do all of these bundles. If the source remains, you're not going to win that battle. And that also goes for patients who have implanted catheters or ports or those sorts of things. They have to come out in order to get control of your infection. You want to narrow the antibiotics as soon as you have evidence of that organism, as soon as you know what it is and the sensitivities for it, you want to drop the other antibiotics. Patients do not survive more if you keep them on more antibiotics for longer. It's just not the way that it works. And obviously, how long you treat depends on the underlying infection. But it's about 7 to 10 days. But most things, obviously, our patient population, endocarditis is a little different, and bone infections, etc., a little different, but it's about 7 to 10 days. We recommend assessing the antibiotics daily and de-escalating them. So if it's not being addressed on rounds, make sure we're bringing it up and saying, hey, this person's on day 7 of all 3 antibiotics, we should think about de-escalating. And then the procalcitonin. People either love or hate procalcitonin, and ICU, we like it a lot. It should never be used on its own. It is not a diagnostic marker. You cannot get a high procalcitonin and say the person is septic or has an infection. But it helps you with other clinical aspects. So if they have SIRS and they have an infection and you're worried about them, then and their profile is high, then that goes with the picture of an infection. If all of their other markers are normal and they have an isolated hypercalcitonin, we don't really know what that means at this point, so we don't recommend throwing all of this stuff at those patients. What it is very helpful for is de-escalating. So as your procalcitonin comes down, that is an indication that your infection has improved or is improving, and you can stop antibiotics once it gets low enough. The other thing it's very helpful for the inpatient side of things is if a patient was admitted with an infection that you were treating and they improved, and then suddenly their procalcitonin starts going back up again, you worry about hospital-acquired infections. So that might prompt you to think, I better reculture them again, or I better check some of these other labs and make sure that they're not also going towards an infection. So it's helpful in conjunction with other clinical signs and symptoms, but it should not be used in isolation. And then fluids. So if your patient needs fluids, what are you reaching for, ordering, I should say, or what should you not be reaching for, is the question. It's probably a redundant question, because I've not seen this stuff starch for a long time. But once upon a time it was used. And the reason I think it's important to remember is because it has been studied, these fluids have been studied, and it's changed even in the last 4 to 5 years. But what you don't want to use is starch, should you ever find that on your electronic health system. That is associated with worse outcomes. So if you pump all your patients with starch, they won't do well. Albumin is a very grey area for fluid. So if you've given somebody the appropriate fluids, your 30 ml, and they just don't look like they look like they need more, they're not quite resuscitated, but you're worried about your heart failure patient or these other patients, then you can use albumin to help bridge them through that gap. It can be very helpful. And clearly you don't want to overload with a lot of volume, but it generally is not your go-to for hypertension related to sepsis. You will see it used in other diseases and other forms of hypovolemic shock, but it's generally not advised as your initial volume fluid in septic patients. So we talked about your 13 ml. It's typically crystalloid. It's lactate or it's normal saline. Most of us have moved towards lactate now, just because of the kidney associations with improved kidney outcome. But to be fair, they're both very similar and can be used. And then, like I said, if you need to keep giving a lot more fluid, you can think about things like albumin. We did talk a little bit about that. Okay, and then pressors. So you've tried that, given your 30, the patient is still in shock, MAC is 55, 60, you need to pick a pressor, their heart rate is 86. Which one are you going for? Norepinephrine. Okay. So you put them on norepinephrine, and now they're maxed, and then their heart rate is the same, 90, and then their MAC is 60. Okay, good job. Okay, so this has also changed. So it used to be that there were different pressors for different diseases that made the ICU very exciting and elitist, and now it's not the case, right? It's norepinephrine for everybody, so basically anybody could do it. So you basically want to use norepinephrine for all forms of shock initially, but for septic shock particularly. And then your second line is vasopressin or epinephrine. We usually would use vasopressin, depending on how sick they are, but we usually go with vasopressin next, and that helps you to lower the dose of norepinephrine that is needed to maintain their MAC, and hopefully reduce some of the complications that norepinephrine gives you, such as tachycardia, some ischemia, some cardiac problems. But epinephrine is also a very good second line. The point of that question is that we don't use dopamine anymore. So dopamine was originally in the initial trials and was very strongly used, but we don't use dopamine. It's dropped all the way down to like third or fourth line pressors. For almost all diseases, but particularly for sepsis, it's associated with tachyarrhythmias, MIs, and other cardiac complications. So we talked about moving towards dynamic fluid resuscitation monitoring versus static. So when the initial trial came out, we were putting in central lines, measuring CVP, checking the skin turgors to see how things were going. Now we're moving towards dynamic measurements, which I will say this institution does do very well. And when I say dynamic, we are talking about ultrasound. So you want to look at the IVC. If you gave them 30 mLs and the IVC is still collapsing, then you give them more. If the IVC is plump, they are no longer in need of fluids, and you want to move towards presses. And so I guess in those instances, like you're asking about heart failure and with your other faculty within the ED, if you did give a litre or 2 litres and it's a little shy of the 30, if you ultrasounded them and they had a plump IVC, then you're probably okay to not give the full 30, but you have to have objective evidence that they are already fluid or resuscitated. Other things that we do is if they have an A-line, we measure their pulse pressure variation. So you want to see if you have a variation in that A-line waveform with breathing in and out, that indicates they are dry, right, because they're intravascularly depleted. You can do a passive leg raise. In fact, I don't know if Tyson is here, but he did one the other day on rounds, which not many people do them, but he did. If you lift up somebody's legs for a couple of minutes, you have about 500 cc's of fluid in your legs. So if you lift their legs up, it's like a 500 cc bolus. So if you notice that when you do that, their blood pressure comes up, then that means they are still fluid responsive and you want to keep giving them fluids. If you lift their legs up, but you have to hold it there for a few minutes, and nothing happens, then they don't need fluids anymore. So these are dynamic measurements that we do in the ICU. We're moving away from the CVP. And you should be aware that CVP has fallen very much out of favour in almost all areas. I know the cardiologists and nephrologists will not like that, but it's very, very unreliable for volume stats. So we really don't use it for monitoring volume stats anymore. Steroids. So you don't use steroids in septic shock right off the bat. You have to have a patient that had refractory hypertension, so shock was volume resuscitated, is on presses, and is now requiring escalating doses of presses. Then you can add corticosteroids, and it's typically hydrocortisone broken up into 50 milligrams to a total of 200. But it's not something that you're doing straight off upon admission. You have to actually have failed other therapies. And then there's a recommendation that it could help. It does not change your patient's mortality, it just helps their blood pressure. And that might buy you time for the antibiotics to do their job, but it doesn't in and of itself help improve overall outcome. And then lactic acid. So obviously you should measure it at the beginning and then measure it post-resuscitation. You should measure your lactic acid until it normalizes. So we see quite commonly that a person came in with a lactic of 12, then they checked it again and it was 6, and then it was never checked again. But as you remember, a lactic acid of above 4 is almost a 50% mortality. So you want to check it till it's good. And the other thing you want to remember is your lactic acid is a helpful marker of hypoperfusion. So if it's high and staying high, something is not being perfused, and that is a problem. And then your clearance is just as important. They don't talk about it as much, but your lactic acid clearance. So a patient who has a lactic acid of 12 that drops to 6 is doing better than a patient who has a lactic acid of 5 that drops to 4 after the same amount of fluids, right? Because it means you're making lactic acid or you're not clearing it at an adequate rate. And so that patient is technically sicker than the one that's clearing it. And that's important to monitor because if your lactic acid is not getting better, that person needs their perfusion figured out, either more fluids, more presses, but it's a marker of poor prognosis or not doing well. Okay, so just so you remember, you want to recognize your septic patients early, right? So whether you're using SIRS or Q-SOFA is fine, but you want to, it's better to capture too many patients and overtreat than undertreat their syndrome. So recognize it early and think about it in the same way you would react if you were called for a STEMI or a stroke, because like I mentioned, this is on the increase. Dynamic changes when you're measuring for fluid responsiveness are very highly recommended, more so than static. And that's important, and it's easier to do in the ICU, but it's important to do that with all of the patients that you're seeing. Okay, so let's talk a little bit about bundles. And I promise you the sepsis response team is good and dead. But the bundle care is still very important. So they looked at approaching a septic patient with bundles, So it's just meaning an algorithmic approach, so following an algorithm versus not. And if you follow an algorithm or a bundle, your patients do better. It allows early recognition, early treatment, and better outcomes. And it should be the standard of care. So they have looked at this, they've studied it. Patients who are getting hospitals that have bundles in their electronic health record, or sepsis teams, or a sepsis nurse, or a help team that goes around recognizing and treating these patients earlier, these patients do better. The odds ratio of them dying from sepsis is less because of bundled care. So I'm not about sepsis projects, I promise, but I just wanted you to know why this is so important. Aside from the global approach to sepsis in the States as a whole, at U of L, as I mentioned, our numbers are not great. Those of you who are new, we did have a sepsis response team. People still have PTSD from it because it went off a lot. But it did help. And so I think it's important for you guys to know that the effort that was made in that year really improved the outcomes at U of L. So we started the project, I guess it was a year and a half ago, the expected to observed mortality, which is essentially the patient comes in septic, you are expecting them to die or not, and what is actually happening. So we should not be expecting patients to die from regular infection or even severe sepsis. What we were having was they were dying at twice the rate they should have done here. And at the end of the 18 months, so our compliance with bundles was somewhere in the range of 32 to 34%, so pretty low. At the end of the 18 months, it was up to 94%. Our mortality dropped significantly in the last year, and patients hit almost every bundle marker for the patients that were being called for versus the ones that we were not being called for. So it makes a huge difference, just further solidifying that bundled care really does work. This is us before, and if you're interested, I can send you the after. But the very big, very tall blue bar is no, which means we were not doing all of these things. So we have the biggest bluest bar. But if you, at least we have some yeses, we were doing things in red. So if you compare us to like trauma or neurosurgery or even cardiology, we were doing pretty well. But given that we are medicine, and given that this is, especially from an IT perspective, this is all that we do, we would expect our recognition of this to be way better. The thing that we miss most commonly is the initial lactic acid, and I think that's much more missed on the inpatient side of things versus coming through the ED. But we were missing antibiotics pretty significantly. And again, it wasn't always fast, maybe the ED wasn't ordering it, or there was a confusion as to who was, but we were missing some really crucial elements. Okay, so I feel like I mentioned most of these things. So identify a patient early, recognize that they are septic, that they have an infection, that they could escalate to sepsis and septic shock. Get your bundles in quickly. The 3-hour one, if you're being called from an inpatient side of things for one of your ward patients, get those things done early and quickly and antibiotics up front, and we can always de-escalate later. Okay, questions?
Is there a really big picture that is 2017 that showed like the bundle mortality perfectly year-in-wise, but then the subset analysis that showed you mortality benefit for fluids and what we had to take?
Yes. Yeah, I think it's because, when you're giving fluids, it's technically a temporizing measure. You're giving your fluids and assuming that you are recognizing and treating that infection quickly with antibiotics. As you talked about sepsis being a syndrome, it can be such a overwhelming response from your body that the degree of vasodilation and chemotoxins from the pathogens are so severe that you can quote unquote burn through that fluid pretty quickly and keep requiring more. Vasopressors are obviously helpful at normalizing your blood pressure, but they are not correcting the underlying physiological, what we now believe is an inflammatory response against the organism or the invader. And so they think that that's what the physiological reason is, but we don't have a good idea. I think about 5 to 10 years ago, it was in fact the other way. Fluids were the most important thing in sepsis. You used to have to get down to the ED and pummel them with fluids and some antibiotics. But we've recognised that actually the more fluids you give above the 30, the worse they do outcomes. And we recognise now that it's such an inflammatory response that causes vasodilation and these other markers to affect your organs and circulatory system, that fluids just temporarily gets you better while the antibiotics are doing the background work. And so for some people, it's just more time from an antibiotics perspective. And a little bit like ARDS that Alessandra was mentioning, you can clear an infection very quickly. So if you check somebody's blood and it's bacteremic, for example, 48 hours later they've usually cleared it, but they are not usually better. So the long-lasting effects of the damage that those organisms are doing from an inflammatory perspective is why the hypotension can linger way after the infection has gone. And so I'm not really sure, but that's the physiology of it.
I think we are done.
Oh,
Anything
really?
else?